Good morning, everybody. Hi, I'm Peter Selby. I'm an addiction medicine physician here at CAMH and professor in family medicine, psychiatry, and public health at the University of Toronto. It gives me great pleasure to welcome all of you. So far, I think we have, all I can see is one attendee, Dr. Alice Ordine. So, oh no, there are a lot more. Oh wow, it's filled up. Oh wow, okay, great. I was only looking at one. So, thank you so much for joining us today. By way of disclosures, we have 0 slides. We're going to invite you to put your comments in the chat and put your thoughts there, and we will get to them as we go along. My role this morning is facilitator, and what we're going to do is go around. First, do some introductions of our panelists who have agreed to be here to provide multiple perspectives to this issue, this question that we're trying to talk about today, which is the role of treatment in addressing the opioid crisis. And then we'll go around sort of 5 questions. Why is treatment important in the continuum of responses to address the opioid crisis? How can we achieve better balance in treatment responding to the crisis? How can treatment evolve to meet the current needs, especially COVID and post-COVID? How do we address the barriers and improve access to treatment? And lastly, how do we ensure that public policy is informed by the best available evidence? So as some of you may know, if you look at the data in Ontario, the number of people with going into the hospital has gone up 100,000 with ED visits from related to opioids, and we have data up till June 2021. And suddenly, prior to the pandemic, it was there, but it just spiked. Interestingly enough, deaths also spiked till up from about March 2020 to sort of May 2020, and then have stayed up at about 18 per 100,000. Now, of course, these are not, when you look at those data, you don't see the disparities that who's bearing the burden of this and where this burden is geographically spread. And so similarly, when you look at treatment, you've got to pay attention to where's treatment and what's happening in that. So it's great that the number of people prescribing buprenorphine has gone up, and currently, by June 2020, the last data we have, there are about 3,000 prescribers. Now, whether they prescribe to one person or many people, that's the number of prescribers there are. But if you look at the percentage prescribing methadone, that seems to have dropped. And so, it's interesting to see these trends. And of course, you want people to prescribe something that is more safe, because we know with methadone in the early parts of treatment, there's higher risk of mortality when people are transitioning. And if it's not done right, you can really harm people. But on the other hand, we know with buprenorphine, retention and helping people stay in treatment is less so than with methadone. So with that, what I wanted to also just invite all of you to think about today with this panel as we go along and do introductions and continue with the panel is that, we have to look at this as the big elephant in the room, and each one of us has a perspective looking at different aspects of this. And we really need to understand that there's no one right answer, but on the other hand, if we come together collectively and look at this entire elephant, we'll get a better picture than the elements that make up this crisis that has become a wicked problem. It's become entrenched in society, and it's getting worse. And so what we're going to talk about is treatment as one of those pillars that can contribute. So let's do this. We'll start off with introductions. So we'll go around the room, the virtual room, and the squares. And so I'd like to start off with our first panelist, Sean LeBlanc. So go ahead, Sean.
Thank you so much, Dr. Selby. Yes, it's me again. I'm very, very privileged and thankful to be here. I've gotten through this whole opioid crisis, strong and resilient, and I just feel really thankful that I'm still here. Treatment, obviously, as Dr. Selby said, comes in many forms, and I think a variety of forms is the most effective. Anyway, a little bit more about me. I'm a person with living experience. I'm in Ottawa right now. I'm from the Maritimes originally. I'm a board member of the national, provincial drug user groups, as well as founding a nonprofit myself here in Ottawa. And one thing I'd just like to point out from the very start was how helpful advocacy was in my treatment and treatment towards advocacy. It was like the symbolic or symbiotic relationship. And I'm just looking forward to speaking to everybody, and we welcome all questions, please. Thank you very much, Doctor.
Thank you. And Sean, I think as part of this panel, we're going to go with first names. So feel free to call me Peter.
Thank you, Peter. You can call me Sean.
Okay, great. Thanks. That's great. Wonderful. So Farihah, let me pass it on to you.
Hi, everyone. My name is Farihah. I am the Ontario Node Manager and Scientific Lead for the CRISM node. And CRISM is the Canadian Research Initiative in Substance Misuse. It's a national research network that spans across Canada, and I'm really, really excited to be here today.
Thanks, Farihah. And Lesley.
Thanks, Peter. I'm Lesley Buckley. I'm an addiction psychiatrist and chief of the addictions division at CAMH. And I've noticed a trend in the intros. People are expanding a little bit into more about who they are. So I'm going to add something and say that I spend my weekends running around to basketball tournaments, watch my boys play. And I have a dog who could end up making a sound, but let's hope not, a pug named Pumpkin.
That's wonderful. So let me start off with you, Sean, and from your perspective, starting with that first question. Why do you think treatment is important in this continuum of responses to address this opioid crisis?
First and foremost, I think treatment got me to a place where I was able to stabilize and then be able to work on the traumas that I've experienced throughout my life. I don't think I'd be here right now if it wasn't for various forms of treatment I've taken and am taking. To this day, I'm on a methadone, a very low dose, but it allowed me time to kind of fix all those things I was going through. The vital needs of treatment, I guess, are best expressed in something I went through last summer. So I founded a drug user group here in Ottawa in 2010, and one of our members passed away in July, the day before treatment. So I'm sorry, my voice is kind of breaking everything right now, but that to me just basically exemplifies why treatment is so necessary, and it needs to be available when people really need it. I've been in, I guess you'd call it forced treatment before, i.e. drug courts and stuff like that. And people are only going to change when they're willing and, and they have the ability to do so. And yeah, I just think that my good friend and fellow advocate passing away, literally the night before he was able to access treatment, basically sums up the importance of this so needed aspect of life. Sorry, I'm kind of breaking up a little right now. So.
Oh, sorry for the loss. I mean, and this is the ongoing trauma that people experience with the losses that happen in this world. So yeah, that's really critical. And that time where somebody may have got turned away because of a bureaucratic issues can really come to bear and have a significant consequence. So absolutely. Let me turn to Lesley as a clinician, as a psychiatrist, as a division chief of addictions at CAMH. Are your perspective on this and what Sean has said? Sure.
Well, thanks for sharing that story, Sean. And of course, that's always on our mind when we have a wait list, right? We just would love to have more services available. We recognize treatment's just one part of the continuum, and of course, all the different parts interact, and that's also really important. Because I come from the medical system, I'm going to sort of think about, maybe medical withdrawal is sort of the best example. And to quote you, Sean, but also Michael Nurse in the first session, who said, we need to meet people where they're at. And when someone's at, a point where they want treatment, we need to be there. And we need to be there, we need to be better and be there, in an easier way, more accessible way. And, because I'm talking about medical withdrawal here, I'm thinking we have to have, services people can sign up for, like a medical withdrawal service, excuse me. And then sometimes we only need a bit of our treatment system. So someone might come into the ED for a very different reason, right? Not really to necessarily make a change in their opioids. They're there for a medical reason or psychiatric reason. And we need to be better there as well to provide the withdrawal treatment so that somebody can get the other type of treatment that they do want. Otherwise, it's a horrendous experience and people will avoid our ED. So we need to have treatment within the addiction treatment system, but also throughout the medical system. So yeah, so I think my theme is that we need to be there when people want us, and we need to be better. We need to be welcoming, person-oriented. We can be better.
Thank you for that response. And Farihah, from your experience in CRISM and as a researcher, what are your thoughts about where this fits in?
Yeah, thank you, Shawnee, for sharing. And I echo sentiments of both what Lesley and Sean says. Treatment really acts as a platform to save lives. And we have to meet people with where they are at, as well as the type of treatment they want. So not, again, the forced treatment. So looking at different aspects of treatment is fundamentally important. I know we'll talk about accessibility in terms of treatment, but I know that when you look at treatment, you look at it as a form, as a platform to really engage with people that can really help them and support them and save their life. We heard a lot of stories about people coming and wanting to get access to treatment and extremely long wait times, but they don't have that time to wait. And unfortunately, we hear a lot of stories where time lapses, and when the treatment is available and accessible and ready for them, unfortunately they may no longer be with us, or they may not be where they were at that point.
So if I can just ask you to build on that a little bit. So, if we look at it, the science is pretty clear in terms of both the medical options that we have that save lives, and that it does. In mental health, there are very few medications that have proven to save a life, what we call a mortality benefit, lithium for bipolar disorder, and really these, and of course, if you want to look at and in opioids with these two, these are the things that save lives. So the evidence is pretty clear. What do you think the research community and clinical community needs to do so that people understand this value? And it's pretty interesting because, during the pandemic, I was also working with vaccine and people with vaccine hesitancy, and the evidence is there that it can prevent hospitalization. But, people didn't want it, didn't believe it, didn't trust it. And sometimes I see the parallels. So I'm curious as to what do you think the scientific community and the medical community needs to do so that this evidence is better communicated, better appreciated, so that people can make an informed choice, despite, in the throes of an addiction?
Yeah, no, I mean, I think that's a really great question, and I'll pass it to Sean in a second. But Sean and I are actually working on a grant to address vaccine hesitancy among people who use drugs. So this is really interesting because we're trying to see different ways and platforms to really convey important and accurate information to people so that they can make an informed decision. And oftentimes they do have the information to make that informed decision, but the accessibility isn't there. So they want it, they know it, the evidence is there. It's not a lack of understanding on their end, but when they want to seek the treatment that they want or are looking to seek, or at the time when they're ready, it's simply perhaps not available. There's a lot of barriers that, again, we will probably get into a lot later on in this panel, but there's a lot of administrative, structural, and systemic barriers that need to be addressed in order to really help ensure that treatment is available. So it's not only just being able to convey the evidence about evidence regarding treatment, but also we know the evidence, but there is lack of access in that end.
Great. So, Sean, do you want to? It sounds like you wanted
Sure,
to follow.
If you don't much mind.
Please.
I'm going to talk about a phrase I use often, and that's called equitable inclusion. I've been a part of research projects where I've been at it at the very end, and I've also been on research projects where I've been started from the very beginning. So if there's anything I would tell researchers, it's just to include the group that you are doing said research on. Also, I believe the community at large is going to respect and respond more so to the research itself. And just like any marginalized community, we just want to be a part of what affects us so vitally. Research, frankly, it's really given me an extra worth. Like it's something that I really love to do. If you'd asked me at 20 years old that I would be a researcher at my age now, I would have laughed you out of the room. But it is something that I really love. It's something that I feel is making a contribution to my community, and frankly, most importantly, it's helping keep my friends alive and people that I love. So yeah, just include us as much as you can and as equitably as you can.
So can I ask, Sean, what do you think were some of the things that facilitated you, getting into treatment, getting into research in this journey? What were some of the things that the system did that, or didn't do, that made it better for you to do this? Or maybe something else?
I would say never given up on me. I had a lot of trauma I needed to heal from, and I was thankful enough to be engaged with a doctor who frankly put up with my shit. He never judged me, and he was just always there to help me. He was also the first person that got me engaged in advocacy, and I was able to heal, the more I was able to advocate. The more I was able to advocate, the more I was able to heal. I've gone through a lot of stigma, despite being, a white, straight man, and that's all been because of my drug use. I just think inclusion, first and foremost, is what helped me personally, and not giving up on me. I think there's, a lot of benefits to everybody. Everybody has something to contribute. There's a lot of lost potential there. And I think when everybody bands together, forms a circle of care, then we're going to have the best results.
Thanks, Rod. So it really sounds like a really important, having a good relationship with a care provider is critical. Not giving up on people is critical. And then watching that journey, being along with that, walking alongside is what I'm hearing. And then that allowed you to bring forth what was in you, in a way, to then give back, and that it was a process. Lesley, I'd like you to also comment on this about how can we as clinicians make a better, make treatment more accessible, make it more understandable, make the evidence more understandable, and share it with potential clients, patients, etc.
So, I do think about, whether maybe there's a sort of historic understanding of what treatment was that maybe is changing over time, but there might be still people who think that treatment is a certain way. So I think we have to, in some ways, promote what we do and what we offer, and probably the best way to do that is what Sean just said. Talking about real stories of real people who've benefited, because that's that just hits you right in the heart, right? That can be useful. Also thinking about, and there's a question in the chat about what type of treatment. And, Sean, you mentioned drug treatment court. When someone's not quite ready for treatment, it may not work. Is there something, even in that, drug treatment court model, is there something like just getting support for something else, not necessarily change, but, where you can kind of like slowly maybe move into a different perspective of what treatment is, or think like, oh, maybe treatment wouldn't be so bad. Is there something there?
I would say not being criminalized. Frankly, it's people who are experts in law who were treating an issue that I had medically. And I think that is not the way that we're going to solve this crisis. I was talking with my partner a couple nights ago, and the drug user group I founded in 2010, I'm the only one left. Everybody was the founder there. So I think it takes a lot of different things and a lot of patience. People are trying to heal from, long-term scars. I never thought when I was 13 years old that I'd ever become an injection drug user, but life happens, and I did. And it was a lot of different people that didn't give up on me, and that's the reason I'm here now. So, yeah, I would say patience and empathy would be those two things.
Yeah. So, we have this treatment is out there, and we, as we said, it comes with heavily, the way it's funded in our province funds a lot of the medication, and it's, on the backs of OHIP, as opposed to a comprehensive model. So what are your thoughts about how we can achieve a better balance in treatment responding to the opioid crisis? Maybe we'll start with you, Lesley, and then go around.
Sure. I think, one place to start is just having more services and disciplines involved in initial treatment. Whether it's case managers, which, are so important. I can't imagine working without social services, accessible, and psychiatry. I'm a psychiatrist, so I do think about whether psychiatry is available sort of in all treatment settings and how that can add something at times if people are interested in it. And also thinking about how we are seeing a lot more stimulants mixed with opioids right now, and how that, sometimes brings people to the emergency room for what appears to be a psychiatric reason. And, how we have to I guess, balance the different disciplines and like mental health and addiction, and also think about, extending stays and offering more hospitalization and care along the psychiatry route, which I feel like is a gap maybe that we could do better at. So yeah, I guess my thought is sort of in terms of balance, just balancing different disciplines to support.
So there's some great questions coming on. Again, I think Lisa Bromley asks in that is, how do we persuade funders that a comprehensive model is better than the current model? And your thoughts about that as well. And I'd open it up to you, Farihah, to talk about that from some of the policy work, research perspective.
Yeah, I think that's a great question. That's something that all our research kind of focuses on. How can we really convince funders and policymakers to make informed decisions? And that goes back to the evidence-based research that we're engaging in, and we're working on the grounds and the community-based work we do with working alongside and as an ally with people who use drugs. For instance, Sean and his peers and colleagues are integrated in all aspects of the work that we do, because they help and guide us in ensuring that we are really collecting the correct information, engaging in the appropriate research to really kind of show them this is the evidence, and then based on that, make these decisions and convince them likewise.
Yeah. Lesley, from your perspective.
I think we need to convince people to invest, right? So people can sometimes understand the evidence and realize it would be a good idea, but they're just not digging into the pockets, to fund it. And it's sort of expensive in a different way, right? So with certain specialties, they bill OHIP, right? And that's less obvious. It's not necessarily new money that comes out, but when we want to build a larger team, it's more of a lump sum investment that comes. And I think that's one of the major barriers, and whether it's just like the ongoing amazing advocacy that's already happening, but how are we going to reach politicians and policymakers and decision makers to put the money where the evidence is.
Mm-hmm. And Sean, from your perspective and with people with lived experience of how would we convince politicians who are there for 5 years, come and go, may or may not,
I guess that we're citizens too. I've been a part of a lot of different projects, and very few of them, if any, have been funded directly. There's drug user groups provincially, there's drug user groups nationally, both of which I'm a board member of, and it's just providing even very, very small funding to these groups. I'd say that first and foremost is the biggest reason, and also it's kind of a barrier, just the process of funding, as I'm sure my other three panels have been through before. It's pretty onerous, the process of applying for funding. I just went through it with a drug user group, a new drug user group called ONCUD that I'm now a part of, and I couldn't believe the work associated with just applying for money. So yeah, just basically fund drug user groups directly, because you can really stretch a dollar a long time, and if anybody knows how to, stretch a dollar, I think it's people who use drugs, frankly.
Yeah, that's a great point you make there in terms of making sure that the funding comes through. One of the questions is that we know that the Canada Health Act, actually, the federal transfers are for physicians and hospitals, and I sometimes wonder how much of these structural issues drive what we end up seeing, because that's what comes. And with OHIP, it's a single pot. All physicians, all disciplines have to do it. And if that's where things get billed, then it lets other parts of the ministry off the hook. So as a result, you get this. I mean, way back in the early 90s, where there was a very small methadone program at the Addiction Research Foundation. There was one satellite clinic in Toronto. There was in London, a few prescriber. The Niagara Clinic had shut down. All of those had medical model, had comprehensive models. In fact, with proper models of care, with therapists and housing and connections and pharmacy involved and physician involved. And I trained in that model. But when it went to actually scaling up and expanding it, ministry said, sorry, no money for therapists, no money for all those other things. Let it come off the back of OHIP. So physicians stepped up and pharmacy stepped up. And that's how you landed up from 300 spots or less in Ontario at the time to what we have now. So question is whether is this, is it a political issue? Is it a legislative stuff or a combination thereof? Because, this means that the province needs to step up and provide those other services. And things like housing fall within the city. So what are some of the ways? Because, if you're helping somebody recover, you can't recover if you don't have good housing. You can't, and yes, you can get medical management, but then how do you get the other things that you need? And I think someone in the chat asked about, do you think trauma therapy is I think Carol Price asked, how important is it to have trauma therapy available? So I'm curious about that because trauma is such a ubiquitous issue. There's 1 in 2 people have potentially experienced trauma. How many of them would we have to provide services for, and how do we do that? So opening it up for your thoughts and comments on that.
I'm someone who has experienced a lot of trauma, a lot of different abuse when I was a young man, or a child, I guess I should say. And that is probably equitable to the trauma that I've experienced through this whole opioid epidemic. I've lost so many friends, so many people I really care about. And I think, dealing with said trauma is it's essential. I personally am seeking out treatment right now in regards to just speaking to someone. And I was blown away at the amount of barriers there are to that. I was an outreach worker for Ottawa Inner City Health for 8 years, and people would come to me, where can I go to speak to someone? How can I get treatment? And despite having lived it, having been in a service provider myself, I never knew how to answer that question. I know personally, it was like, as Peter said earlier, having a house, kind of just basically building blocks up so that, you have that base of support. And it's very simple, just giving someone a little bit of self-worth, providing them with a place. And you'd be amazed at the turnarounds that can actually happen.
Thanks. And Lesley, with that enormous issue of trauma writ large in society and concentrated in people who are using opioids and using substances, how could we actually, is there a reasonable way of figuring out how to provide service?
So, I think we know that it works, right? So, Sean's story of how impactful it is, we know that it comes up all the time. People want it, maybe more than any other type of treatment. And it can be effective. And it's, again, this resource issue of just like trying to get enough people that can deliver it, and then making it accessible, and then designing it, right? So what does it look like? Does it look like the kind of manuals we use in research? Maybe it has some of those tools, but it has to really fit and be kind of co-designed and be, in a palatable way that matches the people who want to use it. And maybe obviously there's not one size fits all, right? It has to be different for different groups. So again, I'm going to go back to that resources, but we know we're not going to get a waterfall of funding, right? So then the next question is, well, what can we do with what we already have? So sometimes we go to groups because we don't have enough one-on-one. How big can those groups be? Maybe we need to start researching some of that. Like, what could be effective with larger groups while we still push for more and more resources.
Yeah. So things like, but of course sequencing it as well, I would imagine, because sometimes, you have to be ready to do trauma therapy. We all need to be trauma informed and come to people with understanding that things have happened to them, and rather than what's wrong with them. But not everybody is ready to do deep trauma work. So we have to figure out how that that work scale, and sometimes doing trauma work too early could potentially cause people to get worse. So how do we get that kind of nuanced information out? Because it's an interesting piece, and people don't need resolve their trauma all in one set of 6 sessions. Or so thoughts about how we as a society actually have to address this, and how does treatment, when we are treating people, how do we at least start that process?
I think that it starts with just being trauma informed in every single way that you set up your system and your center, or whatever your organization is. So that's number one. And expecting, when you start a group or start any kind of treatment or interaction, that could be part of it. And so you want to know that, like in an assessment, right? And then to your point, Peter, like you've got to know how much to ask and how much that person is ready to talk about. And so just being all, very like just having a knowledge base within every member of the group to understand that, what to ask, what not to ask, when to ask it, and then again that evidence, right? So how can we tell when somebody's ready or not? And we have, sometimes we have criteria, and sometimes people want to advance faster than we want them to, but maybe we're wrong, right? So we have to really, I think, be flexible and knowledgeable when we make those plans in our organizations.
Thank you. Just echo Lesley, excuse me. I think consistency is also a really important piece. The reason I disengaged from treatment initially was having to re-explain my traumas over and over again to the new person that was in the community health center or the drop-in center. And I'm not blaming that on any organization or any individual, but I was basically being re-traumatized, having to explain all these horrors in my life over and over again. That's probably an issue of funding. A lot of people move on to other jobs. So yeah, I would say consistency and empathy, and I echo that again today.
Yeah, thanks. Farihah, do you want to add to that piece? And
yeah, I was just going to say, I think the consistency and continuum of the provider is extremely important in that relationship. And a lot of times it also does go back to the funding, as Sean alluded to, because we see individuals that are seeking some treatment, perhaps some counseling services, and then they go for their 3rd session, and all of a sudden the service is shut down. There's a disruption of service, so the funding has stopped, or that individual is no longer there. They've been routed to a different kind of service or area within their organization, and there's all of a sudden this big disruption, and that really stalls or impedes on the ability for an individual who is seeking the care and that treatment and that service to continue on their path. And we see that a lot in the treatment sector, unfortunately.
Well, healing relationships are so critical, and continuity is so important. We've known that for for a long time, not just but again, if you have people who transition or turn over a lot, that doesn't lead to trust, especially when people who've been traumatized. Why would you trust a system that costs, you're a number, and then people are moving? It's very interesting to pay attention to this change in society. I mean, and if you look at some of the issues around, one of the features of a substance use disorder is being disconnected from community, from self, from others. So if the treatment system is going to adapt, it needs to get more connected and have consistency in its connection. And this is, I feel, sometimes where the pharmacist can have a huge role, right? Because they're seeing somebody almost, especially with methadone, at least in the early stages, are seeing them daily for the first few months. And again, we've seen a shift in pharmacy as it become much more corporate, that it's not the same pharmacist that they will necessarily see. But I've always wondered about that, and curious about people's comments about, it's not just the doctor and the client. There are other members there, even in this medical model, that can make a difference. So comments about that, or thoughts about that, especially Sean, from you.
Okay, I'll try it first. I agree wholeheartedly. I'm on a low dose of methadone right now, and they're great support to me. The place that I go to now, they've got counseling. They're actually getting people engaged in forms of treatment. They're providing methadone, buprenorphine, and just that relationship that I've had with this individual that runs the pharmacy, it's been fantastic. They've never judged me. They've always tried to help me solve my problems, and always basically there for me. Just, it takes a village to raise a child. Well, it takes a community to really help someone who's been as traumatized as many people who use drugs are. So yeah, I think it's vital. I think it's as essential as doctors and nurses and everything, pharmacists, counselors, you name it. And I'm only here because of so many different people's help, and I can't emphasize how vital that was and how much it means to me.
So staying with that, thank you so much for that, Sean. And I'm sure this is a big shout out to all the people who you found helpful. So that's great. And yeah, I think there are sometimes in our system there are these unsung heroes outside of the prescriber who do help. But I'm curious as we look at the system of treatment, how do we make that more trauma informed and less traumatizing? So right from the front desk staff to the urine collection piece that is, for contingency management. Your thoughts, and maybe we'll start off from a research perspective and come to you, Sean, last. But Farihah, what do you think about that process of care? That design of care goes back to the 1960s or 70s when methadone was developed by Nisranda and Dole in New York with a grant from the Rockefeller Center. But that has perpetuated. So your thoughts about how do we, what are some of the policy level work or research that has to happen to improve this model of care?
Yeah, I think first and foremost, we have to really recognize the stigma associated with treatment. So, for instance, individuals that are going to the pharmacy to pick up their treatment, there's this essential liquid handcuffs. They have to go to a separate window, a separate line. It's very stigmatizing. It's very uncomfortable. We need to recognize the role that stigma plays and the impact it may have on people who are choosing to engage in treatment. The treatment providers come in all different forms and shapes, as we just mentioned. And I think recognizing that and their role, and exactly as you said, as the front desk, the receptionist, the counselor, maybe someone that's facilitating scheduling, they all play an extremely imperative role. And perhaps even one bad interaction or one stigmatizing interaction can really offset an individual and discourage them for proceeding with their treatment. So I think the role of stigmatization and the recognition of that is absolutely fundamental in research and policy and in the actual systemic administration of treatment.
Mm-hmm. Thanks. Lesley, your thoughts about that topic?
I've really liked the conversation about relationships. One of the things I think that maybe gets in the way and might be related, Sean, to like, why am I asked every time the same questions is like provider anxiety. That we work sometimes in these rigid ways and maybe afraid of getting in trouble if we didn't ask about trauma. And maybe we should, maybe we should know when someone has trauma, but maybe there's a way to just keep a record that's more clear in the charts. So we don't have to ask it every time. To help people, providers, I think like be taught in a way by hearing what we're hearing today, like just the importance of connecting. And then, also maybe being yourself. There was an interesting podcast I listened to recently on burnout in medicine. And they were talking with providers, oncology, cancer treatment folks in the US at a major center. And they were talking about their own burnout and having to speak with someone. And they were getting trained about how to speak with somebody about giving a diagnosis. And one of the people that was training them said, like, well, maybe one of the barriers here is that you're really sad for this person, but you're not like saying that, because there's this like, kind of like locked up way that we have to be. So, whether it's sharing our own emotions or, showing that we care, we could do more of that than maybe we're told we can. Maybe there's something in our head about professionalism that is a bit of a barrier to maybe being able to be more relational in interactions.
Yeah. Thank you. That's really important. That the trauma they've experienced is not necessarily one way, and it's not just necessarily that the person experiences trauma. That people who come to this work have been traumatized. People who are in the moment feel compassion and feel hurt by what they're hearing and being witnesses to that suffering. And the mechanisms of our health system don't allow for the providers to have that support. I've done some implementation work in other countries with mental health systems, and most of them happen in primary care. But a strong pillar for all mental health care implementation there is provider mental health and support. It doesn't happen without that. It's not allowed to happen without that. But it's very interesting to me here in Canada. It's like we just throw people to the front line till you fall and replace, fall and replace. So it's like, there isn't this idea that providers are human too and need things. So sometimes when a provider comes across as grumpy or angry or judgmental or something, it may have nothing to do with you. It may actually have to do with their own issues going on, and we don't have a good system to help people be human. So I think that's a really important point. As an area of post-COVID is that we've really got to figure out who's taking care of the providers. And I think especially in people that are working in opioid agonist treatments or treatment systems need their own support, I think, as going forward. So they can be better with their clients and helpful. So as I'm saying that, Sean, what are your thoughts about when you hear Lesley talk about it and me talk about it? What are your thoughts about this?
I would say, first and foremost, including people who've been there and done that. I was an outreach worker for our local inner city health organization for 8 years, and my main role was helping people navigate the health system. There are a lot of barriers there, whether it's like taking 3 buses to get there, dealing with the security, having those personal interactions on the bus. And it was amazing how people's, I don't know if I would say guard, would drop, but just how open and courageous they were once they had found out they were with somebody who had gone through similar things that they had. A lot of people aren't able to navigate those systems on their own through all those barriers. And I just think having somebody with a bit of experience to help them navigate said barriers is most important. And it's something I take very seriously and something I really see as a privilege. So yeah, just meeting people where they're at and having people who've been there to meet people where they're at, I guess would be my answer.
That's great. Thank you. I'll go to what Lisa Bromley said, which is people will do things that they are held accountable for. And that's an interesting statement. Yes, all of us respond to accountability. And how can we build accountability for quality example, trauma treatment into the system? Yeah, go ahead.
I can just try this. I know Dr. Bromley personally, and every single time I've had an appointment with her, she always asks me, "How are you?" And not in any kind of condescending way. She really actually cares what's going on with those that she's helping. And I think just having that available, sometimes I'd say nothing. Sometimes I'd probably talk her ear off way too much.
Yeah.
So, yeah, I don't know if I'm necessarily answering that question very well, but I think that example that doctors like her said have been vital and are instrumental to people like me healing.
Lesley, what about in your thoughts, the accountability for healthcare providers or the system to provide quality?
So I think back to what you said, Peter, about the early days when the system was getting set up, and I think in the U.S. in certain areas it was mandated that that in any kind of like OAT treatment had a bunch of different things there, and so that having a policy like that enforces the inclusion of certain services that are thought to be really important could be, one way to do that. And then the resources have to flow if you can create the policy for it.
Okay, great. And Farihah, from your perspective.
Yeah, I think ensuring that there's the resources for and available to support the providers when they are engaging and interacting with their clients, so that they're not burnt out, they're not restrained with time. For instance, they're double booked, they're triple booked, they have jam-packed days, and they just want to go in and out and not really have that meaningful or fruitful interaction with their client at that moment. So really, just making sure the resources are available to help facilitate and foster that.
Yeah, and if I can just add to that, here's the thing. Sometimes when you put these accountability measurements, as soon as you start measuring, that measure stops becoming helpful because people start gaming the system, the providers. So that's one thing. And I'll share some anecdotes. So one of the reasons why a lot of the methadone programs got stuck in Canada were it was mandatory that people had to attend treatment and therapy. So whether they wanted to be there, they were there. And then a colleague of mine who ran a large methadone treatment program in Illinois started trying to get more recovery oriented, and they noticed that the bulk of the people who they were caring for were unemployed. And they thought, oh my God, we're really doing a great job with people's unemployment. But these people were stable on methadone for a long time. And so then they decided to just ask them, like, hi, how come you're not working? So, well, because I won't get my methadone if I don't show up for all day programming here. So there was no transition from one system to the next to allow for recovery as people got better. So I think we have to be careful with these accountability things that some bureaucrat puts into place, because it could create all these unintended consequences. And sometimes another observation I'll make is that a publicly funded system only allowed methadone clinic, the pharmacy, to open at 6 a.m. And guess what? If you work construction, you need to be on the job site at 6 a.m. So, but guess who stepped up to that? I'm no apologist for corporate, but Shoppers Drug Mart was way back, opened up. Their 24-hour locations in Toronto opened up. And so, there's a question of how do we create these accountabilities, but not suddenly hamper people from getting what they need to do to get better at their time. So Lisa, I think that's a great question, but I think we need to figure out, it's a bit more nuanced than simply saying everybody has to get X number of, or you have to provide this, otherwise you're seen as a deficient service, because not everybody coming into that service might be ready for that trauma care or what have you, and we need to figure out how to walk with the client on their journey. And that journey is not short; it's a long journey. It's a lifelong journey. So just want to put that out there as a thought. Coming on to some of the the questions again in the chat. This is a question from Carolyn for you, Sean. What do you think about peer-based models for treatment? There's 12-step models, which tend to be polarizing in harm reduction circles and almost taboo to talk about in harm reduction. And Carolyn talks about occupying both harm reduction and 12-step spaces. And they found that both saved their life, and gave you good quality of life. Also understanding that doesn't work for everybody. No one size fits all. Weird that there seems to be this divide between funded and organized treatment and peer-based treatment. So your thoughts about that?
I guess first and foremost is whatever works for anybody, is going to be the most effective way of delivering these services. I, for myself, am not someone who's really benefited from 12 steps, but that doesn't mean I don't know a whole host of people that have. I just think in having varied models, as you mentioned, Peter, earlier, having been provided at different times, it's amazing how little and nuanced treatment can be to different people. For me, it was advocating for my community and getting good feelings about that, and starting to rebuild my self-esteem and everything. Some people I know, though, they need to go to 12-step meetings all the time. One thing I've noticed recently is I do feel that the communities are coming together, the harm reduction community and the 12-step community. At least locally, we've had some groups reach out to us in regard to some events we have throughout the year, like Overdose Awareness Day, Drug User Memorial Day, and I'm really inspired by that. I think we need, many different flavors to make the soup good, and I think 12 steps and smart recovery and whatever it is that helps people, I'm all for. So.
That's great. And I think Carol said something, is that we are in this work because we care. We need to be able to express that. Okay, so everybody's saying, yeah, it's 11:25, so we have about 10 minutes. So let's move this to some of the issues. And I think we've talked a lot about them anyway, as we've just had this conversation. But I want to make sure we go around and ask people if they have thoughts about how treatment can evolve to meet the current needs that are going on, that you're seeing. So let's start with you, Farihah, from a research perspective. How do you think treatment needs to evolve?
Yeah, I think we saw a lot of changes and disruptions because of COVID, especially at the beginning. I think treatment just really needs to be adaptable. It needs to be flexible. It needs to, there shouldn't be a universal or one size fits all approach, which is a reoccurring theme today. It should be really constructed in a way that an individual, based on where they're at, the lifestyle they have, their work, their living situation, how far they live from the treatment center, for instance, or from the pharmacy, it really should be flexible. We saw a lot of extension of carries over COVID, which has really helped a lot of individuals and build up their life, and really motivated them and encouraged them and brought them on a right direction. So I think the sustainability of those differences and changes should really continue post COVID. But in terms of just treatment itself, I think it must really be adaptable and flexible.
That's right. Thank you. And yeah, Sean, go ahead.
Just to add to Farihah, I couldn't echo that anymore. I've gotten carries recently and divided carries, and I've never been as effective in helping my own treatment as that. It was obviously all due to COVID. Being able to split my dose and everything, it's just really helped. Where I was going to get my dose, it was often very triggering because there's a lot of people who use drugs there in different phases of their treatment. And my doctor was wise enough to just say, this model, this way of doing things is going to help this person most specifically. And I'm glad she did, because, I'm happy, I'm healthy, and I'm ready to help other people. So, yeah, meeting people where they're at, being diverse, and always being there, I think.
So Lesley, from your perspective, what do we need to do?
Well, I love that example. I think that's one great lesson from COVID. And then I think another one, a bit smaller, but that was interesting, was how we, were able to work better with the community. So when people came into, let's say, CAMH, into our medical withdrawal, because, they were screened for COVID and they had been with us for 7 days, they were able, like the residential programs just loved to take our referrals. So we were able to really enhance like our ability to create a pathway for someone to be able to say, if they're ready, okay, you've gone through the withdrawal part, like how great that you can just take that next step if you're interested. So that was something I think those treatment pathways are really important. And that was a little side bonus that happened in COVID. And then I think the other area for evolving is scaling up and how to do it, right? So numbers got worse. Toxicity got worse, more mixed presentations, like different substances. So we need more medical withdrawal beds because of the complexity. So how can we scale that up in our current system, whether it's pushing general hospitals more, for admissions? I think those are some areas, some pointed areas that we can evolve and where we learned from COVID.
Yeah, go ahead.
Yeah, and if I may add, I think also the innovative models of delivery. So we saw a lot of harm reduction mobile labs going around to distribute sterile equipment, and also to collect, and just being able to deliver different models of treatment and care is very, very important, and something that we definitely did learn because of COVID and how effective they are.
Yeah, absolutely. I think that people did all sorts of things in response to COVID, and I think there's many lessons learned that need to persist. It's forced people to become a little bit more client and patient-centered. One of the things that I think we haven't really touched upon today, but again, it's one of the things that has always bothered me about is this is the issue around, the process of treatment around urine collection and witness urines, and the whole re-traumatizing of individuals who've had many boundary violations. So I think we should leave on we have only 4 minutes left, but I just want to make sure we don't, that's a huge thing. We talked a lot about trauma-informed care, but that's a huge barrier, I feel. But I'm curious what others think about this.
Just to touch on it briefly, I agree. And I think Farihah named it really well when she said liquid handcuffs. It was really humiliating to go in and, literally pull it out in front of someone that I had a relationship with for years. I don't think it really necessarily helped my recovery. And a lot of times, because of the field I was in, residentially, I worked with people who use drugs, and I was testing positive for substances I'd never used in my life. I think they're very limited in their scope and their effectiveness, and I think they can be used as a tool, but not in a punitive way. I think maybe that's one way we've kind of gone the wrong way.
It's hard to say it, any better than Sean there. That it's, what's the benefit and what's the cost, and really we need to think more about that and evolve.
And in the last 3 minutes, I think, we touched about the public policy piece, but I think Sev Arslan brings it up in terms of the ideal practice would be to have one doctor for safer supply and OAT, and they have to go to different doctors. And what are our thoughts on this in terms of, this divide that we've seen between safe supply and OAT? And should it be one doctor? Should it be different doctors? Should those two doctors collaborate? What's the benefit? What's the downside?
I think in a perfect world, it would be one doctor, but I think there's also so few doctors which are providing those services that we're basically going to take what you can get right now. Safer supply has saved many of my friends. It's not something that I personally need right now, but I think having it under the same umbrella is essential. It can be very confusing and very hard for people who have enough difficulties throughout the day to go see two different doctors.
Yeah, I think there's so many barriers and systemic challenges already within the system. So just trying to be able to navigate those differences is already difficult. So looking towards a very streamlined, very clean and less convoluted process in terms of being able to access a doctor is important in the treatment system.
Mm-hmm. Thank you.
And I think we're at this moment with decrim, I think, pretty well for sure coming, and this opportunity to leave that sort of legal lens and go to the health lens, and have a more, it looks like it could be a much more collaborative system, right? And get to bring in policing systems with health and public health. It's a great opportunity to bring all these different groups and people together, and be able to make change. And I think that we need to be loud right now, because if decrim comes, but no more services come, then we've lost like that bump that Portugal got, right? So Portugal got double public health, double health funding. So whatever system you're in, whatever treatment you're providing, I think this is like our chance to be loud together to see what we can do to create better integration at this time.
Well, in the last minute, I want to take this moment to actually thank all of you for a really, thoughtful and wonderful comments around these questions. And I think really thinking about this work in progress. This has been work in progress since the 70s, and it continues. And, the opioid pandemic is not done. It's endemic. It's around. It's taking lives, and we need to think about adaptive and innovative ways. But as we are doing that, we need to make sure we take existing evidence-based treatments and make sure that they are becoming front and center. And and it's interesting how we need to have that evolve so that it becomes more acceptable to individuals out there, because it, as we've heard, it can save lives, and we've heard the personal experiences of it. And then it happens in the context of relationship. At the end of the day, it happens in the context of relationship, and the understanding that what has happened to people drives why they use, what they use, how they interact with us, and that trauma is not just experienced by the client, but it's also with the providers and others. And we need to do better at supporting everybody in the system. So policymakers, funders, all of those things need to be shaped so that we can get out from under this horrific loss, these horrific losses happening in society today. So I want to thank our audience and for the comments. And I'll just, as a last parting shot, Lisa, look up the Goodhart Law, which is about measurement and how, unfortunately, it's failing the health systems when they put measures in place. So we've got to think about a more sophisticated way of understanding quality of care than only measurement. It's a bit mind-boggling to a scientist like me, but it's interesting that measures are not turning out to be what they were hoped to be. So, hey, at the end of the day, we're all human. So let's leave it on that. And thank you very much. All right.
Thank you all very much.
Okay.
Thanks, everyone.